May I invite Dr. Alfie next, please?
Respected senior surgeons, my dear teachers, chairpersons, and dear friends. For a safe and effective laparoscopic surgery, proper placement of trocars or ports is very essential. And if the ports are not placed properly, there would be clashing of instruments, and the instruments may be working against the camera, and this leads to a lot of mental and physical stress to the surgeon and leads to conversions and complications. So for proper placement of ports, you need to keep in mind these conventional principles of port placement. We'll take one by one. What is this straight line principle? Biju has already mentioned that. So when you are placing the ports, they should be placed in such a way that the surgeon, its hands, the instruments, the camera, the target organ, and the monitor should be in a straight line, so that the optical axis and the motor axis of the surgeon is in line. If there is a change in the motor axis and from the visual axis, there is a lot of stress for the surgeon. And what is this baseball diamond concept? I think everyone is aware of that. It helps you in triangulating the instruments. First you mark the target organ, and then you construct a diamond shape, and the optical port is placed in the opposite corner, and the right and left working ports are on the right and left corners. So this will bring you triangulation, and there will be no clashing of the instruments. And some original work done by Kushieri and his team has shown that optimum task efficiency is there when half of the instrument is within the abdomen and half of the instrument is outside. Our standard instruments, laparoscopic instruments, are 36 centimeters. So when you make the port, we have to aim for a instrument length half within the abdominal cavity. If more of the instrument is lying outside, there will be more of scaling and more of physical stress to the surgeon's shoulders and elbows. Manipulation angle is the angle formed by the working instruments, and an ideal manipulation angle is 60 degrees for an effective optimal task performance. And the azimuth angle, that is the angle between the optics and the instrument, should be between 30 and 45, and it should be equal on both sides for better performance. So you can see in this picture, here the manipulation angle is 60 and the surgeon is quite comfortable. The shoulder and the elbow is very comfortable. And the elevation angle is the angle between the horizontal and the instrument, and for proper ergonomics, it should be 60 degrees. And this is a very simple standardized way in which you can plan the port placement. And you mark the target organ, and then the surgeon's hand is kept over the target organ, and you draw a semicircular line. So the average surgeon's distance from base of the palm to the tip of the middle finger is around 16 to 80 centimeters. And the port should be placed in this semicircular line. And the optical port is placed just opposite to the target organ, and the working ports are placed at least more than 5 centimeters from the optical, and it allows for triangulation. And this is the planning for a appendicectomy for a target organ in the right lower quadrant, and the ports are placed in this semicircular line. One problem with triangulation is that the camera person has to keep his hand between the surgeon's working hands, and this may be awkward in some situations. So one way in which you can reduce this discomfort is making the camera person sit down, and he will be comfortable. And another technique that we can utilize is called a sectoring or sectorization, where the optical port is kept outside the working instruments. Here you can see that the camera is outside the working instruments, and both the camera person and the surgeon will be comfortably moving the hands. But here you can see that the optical axis and the motor axis are decoupled, as Biju was telling. So a beginner will find it more difficult to have this hand-eye coordination in this orientation. But by practice you can learn it, and it will be more comfortable in doing long advanced surgeries. Most of the time when surgeon is planning for port position, he will be looking at the external anatomical landmarks, and then by his prior experience he will be planning the port placement. And when he sees some scars, usually when you see the previous surgery scan scars, the first port should be placed as far away from the scar to avoid adhesions. And you need to be aware of this anatomy, the epigastrics, to avoid injury to the vessels. And in a patient with a very low placed umbilicus, when you are placing the port of the umbilicus, here if you are planning for surgery in the upper abdomen, the camera port will be way down. So in such habitus, you have to plan the port placement, and it has to be placed higher up. And especially if you are using an angle scope, it should be kept closer to the target organ. And these are the different ways in which you keep put the primary port: the classical closed technique using Veris needle, the open technique using Hessen cannula, and some of the gynecologists put the direct trocar directly, blindly, and the fourth one is the optical trocar or direct vision technique. So the closed technique, you use the spring-loaded Veris needle, and the umbilicus is the usual site that is where we pierce the Veris needle. But when there is scarring in the umbilicus, when there is an umbilical hernia disease in the umbilicus, then you go for an alternate Veris needle site, and usually the Palmas point, that is 3 centimeters below the left subcostal region in the midclavicular line, that is the usual alternate site use. And this is the open technique where you make a 1.5 to 2 centimeter periumbilical incision, and by layer you go and get access into the peritoneum. And this is the optical entry technique, which is very useful in bariatric surgery. And once you have put the first port and then introduce the scope, then you put the secondary trocars under direct vision, and this is the right way of holding the ports, the sharp ports, and your index finger will be supporting the sharp port, and it will prevent the port from overshooting and injuring the adjacent structures. So it has to be introduced 90 degrees perpendicularly in a controlled screwing manner. And earlier studies had shown that 50% of laparoscopic injuries are due to the initial access injury. And the incidence has drastically come down, but still there is a small but significant injury, bowel injury and major vessel injury, and a good percentage of them are not noticed during initial surgery, producing high morbidity and mortality. And this is a systematic review from Cochrane, which included 57 RCTs and around 10,000 participants. But since the incidence of these complications were very low, there was not enough participants, or sample size was very low to get any meaningful conclusions. And when you have a confusion, the associations come with position statement, and we have a statement from the Gynec Association which states that surgeons should perform the technique that they are most comfortable and experienced, and when there is a problem or risk of a complication, he should be willing to convert it to an alternate technique, and he should also be well trained in that technique. Thank you for your patience.
Thank you, Alfie. Well presented. Also, for a multi-quadrant surgery like total proctocolectomy or Whipple's resection, you will have to design the port such a way that you will have to anticipate the axis of different quadrants.
The target will be changing.
Yeah. For example, after a Whipple's resection, if you want to do the hepatogenostomy. Being the hepatic duct is a vertical structure, and intestine you will have to place in a horizontal way. The sutures have to come from up down, means the surgeon has to stand on the left side of the patient. But for a gastroduodenostomy, probably he has to stand in between. So the surgeon position also changes, and the port has to be placed in such a way that he like to anticipate the future procedures.
All the targets should be identified.
And also, while placing the ports, you will have to keep in mind that the surgeon has to stand straight with the spine straight. For example, if you are doing a TAP procedure, you will be placing the 5 ports on either side of the umbilicus. It's better you place the ports above the umbilicus so that the surgeon can stand straight. Otherwise, if you are placing it below, the surgeon will stoop down, and chronically that will cause your spine problems, and the ergonomy will be good in a standing position. So you like to place the port such a way that your this thing is also taken, health is also taken care of.
Thank you.
Good talk, sir.
Last
Covering
comment, sir.
all the aspect of the trocar insertion. It is very highly useful for the beginners,
Right.
also the practicing surgeon. Thank you, sir.
Thank you for the comment.
Thank you, sir. May we move on, please? Thank you, sir. Thank you, Dr. Alfie.